next presenter is McKee, founder of VendRx. By the way, VendRx is one of our portfolio companies, so welcome, Russell.
Thank you. Well, Faye, thank you for alerting me that we can get a digital twin. I have a twin brother, identical, so that would make four of us. All right, well, so I've been here in town for a couple of days, learned a lot about AI. Certainly most presentations include a little bit about AI. And there's lots of other kind of fun things going on with innovation. It's moving super, super fast. There might be at least one thing that those things cannot solve all by themselves. I want to talk about that. I'm Russell McKee. I'm a co-founder of VendRx and a CEO. And let me tell you what I mean by prescription gap. And we'll feature one of our customers here. This machine sits, they affectionately call it their robot. It sits on LSU campus, their student health center. LSU has over 43,000 students, graduates and undergraduates combined. This is where they go if they want to get taken care of. However, as soon as they get their diagnosis and their prescription, they now have to go somewhere else. How many of those patients, students, do you think want to go off campus when they're filling their garbage? Probably not very many of them. So it's a proximity problem. It can't be solved with zeros and ones or units. We have to take prescription medications. We have to ingest them. And we need a good way to store them, track them, inventory them. So it probably affects more people than the students at LSU. People always ask, well, is the problem impacting? It probably has. It's impacted me recently. We don't care about it very much, likely, unless we're feeling like kind of crap. Then we care a lot, because the pharmacy might be the last place, at least I want to go. This problem's existed for a while. It's getting a lot worse. And it's not because the great providers in the industry are phenomenal. It's because the operational costs and the legacy model of pharmacy, it's just not affordable to build pharmacies anymore. So how do you give patients their medicine? Here's another example. I hope I can build a story of traction as we walk through what we're working on. This is an automated machine, self-serve entirely, sitting at an ER in Spokane, Washington. When the pharmacies close at 7 or 8, they have one place in the city of Spokane, a moderate-sized city, to go get their medicines. That's it. So when there's 300 patients leaving the emergency room in the hospital, where do they go? What are your options? Get it tomorrow or not at all? Unfortunately, a lot of people don't get it, period. Statistics say that maybe 30%. Let me tell you another use case, and we're talking about two use cases. These are our primary markets, and we're talking about our beachheads. We're going to go a lot further than that. This is a different hardware platform that's more suitable for clinics. Most people outside healthcare don't know that in 46 states, physicians can dispense medicine to their own patients. It's not so different from the carve out for x-rays. If it's a service to your patient, you can take care of them right then, you should. And so you can do this. It just hasn't been managed. That's why you don't hear about it. We built that product for that, and this is the second time Utah's been referenced. We took a long time to build a contract with IHC. We're going to go into 28 clinics for them. We've already got some down. So now these patients don't have to go to the pharmacy when they're done. So you're looking, you might be tempted, to your point earlier, you might be tempted to think we're a hardware company. We view it as the least of what we do, maybe 5 or 10%, but I've already established that you have to have it. Now, a couple of years ago, that might have been a little bit of at least a curve, a speed bump for us, because people don't like hardware from the perspective. They think it's lumpy. They don't know how to calculate how successful it can be over time. And in fact, it does slow you down for implementations a little bit. But once you get there, it becomes a moat, because people do not replace these things. That's been our experience, and it solves a big problem for them. And so the little sacrifice for the build time and a little bit of operational complexity means that you now have pharmacies that you don't actually have to add on board any other labor or any other services unless you're wildly successful. So if you're talking about price perspective, it's different leagues. I won't give the numbers, they seem preposterous. But if you can do away with all of those line items that cost you to build a pharmacy, and you can treat 80% of conditions on a transaction basis, not on a SKU basis, we're not going to replace pharmacy entirely, because it tells earlier why. I mean, you need to have 2,000 or 3,000 medicines in the pharmacy, but you may only need 50 or 60 or 100. in these locations to take care of most patients most of the time. Okay, I used to talk about TAM a little bit. People like to know the market's big, and healthcare say, stop talking about it, we know it's vast. Okay, great. How do we get to a household name in this market? We're going to create, by the way, we're going to create more jobs for pharmacists because they'll be able to service these machines and take care of patients from home. And so it'll be affordable for operators now to bring in pharmacists. This is where we are. Urgent care, family practice, emergency departments. You've seen some examples, we have others, and the student health center. We've sold a system for a pharmacy operator that's going to put one in Miami International Airport. They had a relationship with the airport authority, we'll leave it to them. That's super exciting. And then you think about the extremity, where can this possibly go? Where, if you're really going to shift pharmacy from something that doesn't work to something that does, we can go all the way to retail convenience stores. And there's probably a lot of work to do from a regulatory perspective, but that's 4 or 5 years down the road, and it'll probably be out of my hands by then. Okay, so who do we play with out there? Again, we are not a hardware company. We understand how prescriptions move and how patients move to get those prescriptions. That's our expertise. We can build different machines for different use cases. These are hardware platforms that can have different software packages to fit lots of different needs. For example, we even have a locker system. There are many locker systems out there, but our customers who are already using this for these things want a locker system from us, so we've already got a contract for that. Haven't deployed. So for the fully automated system, I mentioned already jurisdiction. It's important to remember this. Pharmacy, this can be a remote pharmacy or it can be under the jurisdiction of a physician license. All prepackaged meds that they can buy from outside suppliers that do this for specialty, or they can be their own supplier, and we have customers doing that. We've enabled that. Another printer and specifications on a label. We do that for them. Big machine primarily is a remote pharmacy. This is primarily just clinics. We don't really have much competition. There's no competition for what we call VendRx. For our full self-serve machine, the noteworthy competitor is now Amazon. It was Medavell. Interesting side point, since that transaction, their former CEO was one of our most recent angel investors. So he knows what we're up to and he knows how we size up compared to their product. And what I'm learning from my customers is oftentimes they don't want to give their business to Amazon. And so what we're going to see is an acceleration from healthcare systems that we're working with that come to us and say, how do we help our patients? Yes, locker systems, things that it's an empty box. We don't really compete about that, but you might think about for home delivery here. We're going to be, if we get first dibs of prescriptions, we're going to drive home delivery too. It's a factor, but for now it doesn't compete on an acute level. It does not compete because you have last mile. And even though they can disguise the cost, last mile is way more expensive than most meds that we put through that machine. All right, you don't have to follow all these numbers, but there has to be value besides just the patient. How does the operator or healthcare provider, we make it simple, no friction. This can be self-taught. Labor is a big issue for their staffs. No added labor, no complexity. You can just give somebody access to the system. We track ins and outs perfectly, and they're on board. So again, no friction on the workload. They're convinced that it's actually more secure than legacy pathways for pharmacy. And it can be a benefit to their practice. You may not buy a yacht with it, but if you can take better care of your patients without adding friction, why wouldn't you do this for your patient? This is what it looks like for this big machine. At our price point, I'll get to that in a minute, we drive a pretty good margin on that, but if it averages out at $30, $3,000 per month per site, you can see what these numbers look like. They can add up pretty quickly. So this is if they're 10%, if they have 300 patients coming through this ER, and they have 10% of those patients that want a prescription, not too bad. Monthly profit after the med costs and cost to us as technology provider, $10,500. This one we're real excited about. We haven't released this program yet. Intermountain Health took advantage of it. We're going to make this virtually a no-risk situation, transaction-based model, so we can blanket the earth with it. And this is what's going to drive our growth over the next year. We can do that because we're so convinced that we're driving value for them. So we'll participate as on a transaction level up to a certain number of prescriptions per month. Everything above that's all theirs. We're excited about it because they are really cash positive on day one. It doesn't sound believable, but it is, and we're seeing great numbers from those who have this installed. What does this mean? We've established value to patients, established value to healthcare providers and operators. What about VendRx and its investors? You can see our MMR there. It's pretty good. I can give you details on all these things later. I want to make sure I don't lose my time mark. But pretty good margin. It's a business that it's kind of, you sell the printer and you sell the ink. It's the ink that really matters over time, and our gross margin will increase quite a bit as these numbers start rolling over and over. You've seen some of the foundational customers that we have contracts with. We have more than just these. A lot of smaller urgent care chains are signing up, and they're adding to our traction story. We're now in about 12 states, and we have plans to go a lot faster. This is a very doable number, a $15 million exit run rate within 2 years. We've got plans to do that. After we conquer dispensing at the point of care, at the point of need, I should say, because we're either putting it right where the patient gets a diagnosis or bringing it as close as possible. Imagine a small town in rural Texas. That's what we're doing. After that, we're not done. We've got more things to do. We want to drive up the volume. We can go through this machine. We can do that in clinics with a product that we call Patient Choice. What I'm really excited about, and I've spoken to my great advisor really about, is a recommender system involving AI. We have a plan for that. We haven't built it yet, so we will either partner or build it ourselves. And that really is going to help not just the patient with getting their meds, but it's going to help the providers too, because it's going to look at best practices. It's going to look at what's available, and it's going to help them make the right choice, making it even easier for them to do it on their own. And we have the important thing is we have the footprint where the machines are, so we can drive that. Again, you can't drive that with digitization alone and AI alone. You have to have the sticky form factor where the patient is. That's what we'll do. OTC pairing, we already have this relationship. We won't activate it until we get enough systems out there, but the company that makes Mucinex, we all know that product, and lots of others. We have an agreement with them where we can now be a distributor inside the systems that somebody else is paying us for. All right, here's where the money will go. Getting machines out there. There's a little bit of a cost in the front end for equipment. That's a big part of it. But more importantly, we want to invite the top talent and bring them in and put it around our growth over the next year or two. So I can't tell them that they're all going to be here for 6 months. So a lot of it is bringing the right people to build our team. Right now is the right time for that. And it's the cloth that goes around that we're asking for about 3.5 million. It can be less than that. That'll get us to 2 years. And we are, I think, a legitimate, close, if not legitimate, A right now with these kind of factors. This will get us to a M&A or possibly something else. Are we done? Oh shoot. Okay, that's it. Team, one common team. It's me and a really super smart and experienced core group of technical people, but they're not founders. We want to add that type of person. But more than anything, we've leveraged phenomenal outside advice that we don't pay a lot for. Here's one example, and we've done a really good job of that, and we brought the best minds, but haven't put them on our payroll. That's our team, and I'll take questions.
Questions?
Excellent presentation. Thank you.
Sorry, my name is Dr. Olive Shaw, solopreneur, Orange County. So I came across a similar, I don't know if it was LinkedIn, but somebody had set up vending machines in clinics where people were spending a lot of time waiting. And it's sort of a similar concept, but in addition to medications, they were having healthy foods and getting people where they are, accounting for these standards of living. But they're basically offering food alongside prescription over-the-counter medications. What are your thoughts on that model? Have you had discussions with a similar kind of company, potentially using the vending machines in areas where there's a lot of traffic, and where people are doing a lot of their waiting, traditional waiting rooms, which aren't going to go away anytime soon? But a second question for you was, what were your thoughts in terms of design? So when I first saw that, it reminds me of the scrubs machine where you get your scrubs and go into the operating room. Have you guys looked into different types of design, like a clear design or something that could have aesthetics related to patients that are waiting in the waiting room?
First, great question. That's your presentation. That's fantastic. Two, one, how do you encourage other healthy behaviors once they get their legend medication, right? That's the question. Well, you can see we're going to do the OTCs now. We can bend it with the machines. it wouldn't be very easy to put other things through the machine, but certainly that would be an opportunity when they're interfacing with the machine and you have up to maybe a minute and a half of their true attention, which you never get these days. And that would be a good time to say, how about getting a sandwich here, or how about doing this, or how have you thought? Because remember, we already know exactly what their medicine is, and if the providers or the operators are going to give us all the other information about their health, you know, abiding by all the privacy and HIPAA laws, if we can do that, we know a lot more about them too, and we can point them in directions for those types of things. Design, I love your idea. For some time we thought about putting at least some kind of acrylic so they can see the robot inside doing this thing. Some of our customers call it the claw.
Yeah.
Because that's really what it is. But to that point, we do have multiple patents on the hardware part of it. You don't see it because what you see doesn't matter too much. Well, the inside does matter. I'll give you two examples. One is the machine on the inside is a two-dimensional array for medicines. It's not stacked in depth like a conventional vending machine. That's how you can get 70 or 80 or 90 meds, because every cell is a unique med with a unique serial number in some case. So we can be that precise. We can cut out recalls. We can shut down expires. None of that goes through. So we've never made a bad dispense. People ask, well, how's that even possible? Because you should never say never. Well, we catch on the inside. It's all driven by barcodes. If there's something that's not right, it leaves in the storage rack. It never goes into the back rack. The other thing is printer. We don't try to kill labels from, let's just say, a stack of Avery's on the inside. That's the only other option to do it. So the seed information is actually printed. We put a patent to that too. The claw grabs the medicine, brings it to a printer, drops that information on it.
Thank you.
Yeah.
Okay. Any more questions?
I actually have some questions.
Sure.
Okay, so, hi, my name is Patricia Shaw. I would just say entrepreneur, done a lot of that. So my question is, like, who fills the machine? How do you get notified when it's running low? Like, those things. How can you acquire it yourself, and then just, are you responsible for it? Like, how does that work? And who's saying, like, this medication is okay? Like, does it fall on the vendor who is purchasing the machine, or is it?
Those are good questions.
Yeah, like the
let me
pharmacy
grab those three, and then
dispensing
I'll
it.
give it back to you if you have more, because I won't remember.
Okay.
Okay. First question is, again,
Patricia.
Patricia, what's the first question?
The first one was, like, how do you know when it's running low?
Who's
Who
refilling
fills
it?
it up?
When we know what they want, because they tell us, they give us their prescribing information, so it's all prepackaged to exactly. If you want a prednisone 20 count and a 21 count, 20 milligrams, you can do that. Most of the time they'll standardize around drugs like that, but you can be very precise. That's what repackagers do. Or if you're doing it from your own central pharmacy, which we enable, you can do it that way too. If you set a desired stock, and you do that through a back-end portal, I said this is 95% non-machine, it is. There's lots of reporting features, lots of fun things you can do there from a management perspective on the back end. It's there that you might set desired stock. When desired stock drops, if there's a decrement of one or many, we know. It hits our database immediately. We can notify them by phone, by text, by email, whatever you want. So that's how we notify people. How do delivery? They do it themselves. Medicine ships to them and they install the code, multi-factor code that pops open a panel, then they can put the medicines in. It looks like a wine rack. They can put 52 meds in that wine rack in a minute. They walk away, push load. Robot grabs them, puts them away. Until the patient comes up and needs to be served, it serves the patient, then it continues, resumes what it's doing. In the future, we already have UPS dropping your medicines on your front door, not in your hand, right, on your front door. That's way less secure than what we do. It would be fun, years down the road, to say, hey, well, why is it that, if they're part of the chain of custody already, why can't those delivery people put it in the machines? We'll have Louie's help and other people's help, maybe 2 or 3 years down the road, so that we can serve rural towns and you don't have to have a pharmacy operator and call it, in Austin, taking care of a tiny town 2 hours outside of Austin. But right now, it's pretty manageable. They can just send, based on their usage, they can send one of their technicians around. We record everybody that does everything with the machine anyway for them. They go in, they plop them in the little zone, push load, go away. Third question. I don't.
That's okay.
Sorry.
And then
Catch me
I'll get
after.
you.
Thank you.
Sorry, Russ. Russ will be here. He'll be around, right?